Hello, everyone, dear colleagues. It's my privilege to present the results of randomized trial testing clinical utility of genomic profiling in patients with metastatic breast cancer. My name is Fabrice Andre. I am a medical oncologist at Institut Gustave Roussy. What are the questions related to comprehensive molecular profiling in patients with metastatic breast cancer? The first general question is whether profiling a high number of genes is effective in patients. Then the second question is how to interpret a genomic report. Finally, there are some translational research questions like what are the new predictors of drug efficacy? What are the molecular characteristics of cancer? And which technology for genomic profiling? In order to address this question, we have designed a study named SAPHIR-02 breast trial, where we included patients with metastatic HER2 non-overexpressing breast cancer who are resistant to endocrine therapy if the tumor expressed hormone receptor and previously treated with a maximum of 1 chemotherapy. The patient received, when feasible, a biopsy of metastatic site, or we used a biopsy performed less than 12 months or a ctDNA sample in order to profile the cancer thanks to next generation sequencing and copy number analysis. The patient received chemotherapy, and after 6 to 8 cycles of chemotherapy, if the patient presented a response or a stable disease, then the patient entered in the randomization phase. For patients who presented a targetable molecular alteration, the randomization was done between 9 targeted therapy versus a maintenance chemotherapy. And this included 2 different trials, one specifically dedicated to PIK3CA mutation with alpelisib, and another one that included 8 targeted therapies. So this is a randomization between 9 targeted therapies matched to genomic alteration versus maintenance chemotherapy. The analysis included a hierarchical testing. In the step 1, we tested whether in patients who presented an Escat-1-2 genomic alteration, the matched targeted therapy improved PFS as compared to maintenance chemotherapy. In the step number 2, we tested whether in the intent to treat population, the targeted therapies matched to genomic alteration improved PFS. This led to 2 questions. First, what is Escat classification? Escat classification is a framework of actionability for genomic alteration, meaning it classified the genomic alteration according to the level of evidence associated with its targeting. In the Escat-1, the alteration, genomic alteration drug matched is associated with improved outcome in clinical trial. In the Escat number 2, the match between genomic alteration and the drug is associated with tumor response, but the magnitude of benefit is unknown. Then beyond Escat-2, there is no evidence of anti-tumor activity. The second question is, what are the hypotheses in this clinical trial? In the first step, the hypothesis is that targeted therapies matched to genomic alteration, classified Escat-1-2, improve PFS with a hazard ratio below 0.51. And to reach this goal, 85 events were necessary. The second step and the second hypothesis, hierarchical testing, tested whether targeted therapies matched with genomic alteration improved PFS in the intent to treat population. And for this, a total of 205 events were necessary. Finally, the trial had also an immunotherapy arm that was previously reported. Let's go now to the result. As mentioned in the first slide, there are three questions that we are going to address. The first one is whether genomic profiling has clinical utility in patients with metastatic breast cancer and how to interpret it. 1,462 patients with metastatic breast cancer were included in this trial between 2014 and 2020. A targetable genomic alteration was observed in 646 patients, and as planned, 238 patients were randomized between targeted therapy matched to genomic alteration versus maintenance chemotherapy, and 115 of them were classified Escat 1-2. The results show that targeted therapy matched to genomic alteration improves PFS from 2 months to 9 months in patients presenting a genomic alteration classified Escat 1-2. The hazard ratio here was 0.41, and the p-value was significant. That was the first step of the hierarchical testing. We performed a subgroup analysis within this Escat population, and although there was no significant interaction, there was some difference in terms of activity between different classes of drugs. Because the step 1 was statistically significant, we then moved to the overall population that included 238 patients. In this group of patients, there was no statistically significant improvement of PFS by targeted therapies matched to genomic alteration. When we perform a subgroup analysis, the Escat classification was associated with a predictive value for the benefit of targeted therapy with 0.48 in Escat 1-2, 1.15 hazard ratio. In Escat beyond 1-2, the interaction test was highly significant, meaning that genomics can improve outcome in patients with metastatic breast cancer only in patients with Escat 1-2 genomic alteration. Let's go now to the last two questions. First, what is the genomic landscape of metastatic breast cancer? We previously reported the mutational landscape. Let's see now the copy number analysis, and we focused this analysis on the question about what are the genes presenting copy number alteration enriched in patients pretreated with CDK4/6 inhibitor. 102 patients had been previously treated with CDK4/6 inhibitor, for which we had the DNA copy number analysis. In this group of patients, we identified 13 genes altered more frequently when the patient was pretreated with CDK4/6 inhibitor. And interestingly, one of these gene alteration was amplification of CDK4 that was observed in around 10% of patients pretreated and who became resistant to CDK4/6 inhibitors. Last question, can we identify new genomic markers of drug sensitivity? And here what we could observe is that patients who presented a loss of heterozygosity for BRCA or homologous recombination deficiency assessed by HRD score had longer PFS when treated with olaparib and when they presented, of course, a BRCA mutation. Conclusion. Genomic profiling has clinical utility in patients with metastatic breast cancer only when the decision to administer a targeted therapy is driven by a validated framework of actionability, meaning that genomic reports must rank the genomic alteration according to this validated framework of actionability. Subset of patients who become resistant to CDK4/6 inhibitor present a CDK4 amplification in their tumor, and homologous recombination deficiency, loss of heterozygosity are associated with the longer PFS in patients treated with olaparib and presenting BRCA mutation. I would like to thank all the colleagues, the patient, and Breast Cancer Research Foundation and Fondation ARC pour la recherche sur le cancer for their support. Thank you for your attention.